for inviting us and giving us an opportunity to share our experience of using amnion cells for bronchopulmonary dysplasia. So we're going to share our experience of using these cells. And at the outset, I want to say that these cells are nowhere near clinical use. We are still trialing them. So I just want to put it out there to start with. So to start with, I want to share a personal story. So this is a picture of Brooke Hansen. Brooke is a ex-Olympic swimmer, multiple gold medals and Olympic medals during her time. This is her story, which is online, and Brooke is quite open about this. In 2012, I looked after Brooke's baby Jack, who is in that picture with Jared, who's the dad. And Jack had severe bronchopulmonary dysplasia. As you can see, is a big child in that picture with a endotracheal tube, and had complications of pulmonary hypertension, so severe BPD pulmonary hypertension. Around that time, I looked after this family for 9 months. Unfortunately, Jack passed away. And around that time, my colleagues here at Monash University and the Ritchie Center Hudson Institute of Medical Research were experimenting with amnion cells in the preclinical space, in the small and large animal models. Brooke was aware of this, or she was aware of what the experiments were going on, and she asked me at that time, can we do anything for Jack which might give him an opportunity? And I can tell you that my involvement with the cell therapy research had been triggered by this experience with Brooke, and I owe it big to her for this. And since then, we have been running a number of cell therapy trials. Right now at Monash, we have 3 cell therapy trials running. One of them I spoke about with Lindsay a few months ago at this seminar series. And today I'll share the story of the amnion cell story. So, neonatology became a bit more of a cover poster boy in the early 2000s with this Life cover, which I'm sure all of you have seen and use frequently in your talks, which basically brought, preterm care and newborn care into the limelight for the public. And the US Today magazine in 2012 or so published how we are starting to get better at keeping very small babies alive. And you will agree with me that these numbers are even better now. So just looking at our survival outcomes from the Australia-New Zealand Neonatal Network report from a couple of years ago, as you can see, after 28, 29 weeks, most of our babies are really good in terms of survival. And if you look at those numbers below 28 weeks, obviously, we don't have a lot of experience looking after the very small babies still in Australia. So the confidence intervals are quite large in those numbers. But if I look at data from my colleague Rose Boland in Melbourne, she's published this from our WICS cohort, where she's looked at various epochs of care provided to live birth babies in Victoria from 1990 to 2017. And you can see with every 5 to 6 years, our survival rates for these babies is going up. At 22 weeks, we're still not looking after many, so it's not great, but the numbers for 23 onwards is going up. So what that means is the absolute number of babies surviving in Australia and in the high-income world is constantly increasing. But what is happening to these comorbidities? So one of the comorbidities which we are interested in, and is the topic of this discussion today, is chronic lung disease or bronchopulmonary dysplasia. So these are numbers again from the Australia-New Zealand Neonatal Network, and they are in 3 kind of subgroups. The bottommost is babies born between 29 to 32 weeks gestation, the middle between 26 to 28, and the top one less than 26 weeks. So if you look at from 2011 to 2020, we are not actually getting better at keeping their lung disease or neonatal morbidities down. In fact, if I showed you data on any of their other problems like brain injury or retinopathy or anything else, it's actually not getting better. And I think it's actually getting worse. So with more babies surviving at extreme gestations, younger gestations, the morbidity of these complications is actually getting more. So there are more number of babies in absolute terms or in percentages actually contributing to the morbidities associated. So you'll agree with me that although we are getting better at keeping these babies alive, we are not getting any better at keeping their complications due to neonatal care and being born very premature. So I don't need to remind this group, or most of you are aware that there is a number of factors which contribute to the new bronchopulmonary dysplasia pathophysiology. In most of these antecedents and pathways, what is common is inflammation. And what is probably common also is the fact that there is a lot of contributing factors which are alterable. And that's where things like cell therapies and stem cells comes into. My colleague and friend Vineet Bhandari eloquently summarized the emerging potential therapies in the management and prevention of bronchopulmonary dysplasia. And a number of these therapies are either ongoing or completed. So we know about the early low dose hydrocortisone story from the United States as well as from Europe, and none of them actually showed any benefit for bronchopulmonary dysplasia, albeit there might be some benefit for mortality. Brett Manley and Omar Camblin are leading the PLUS trial and looking into budesonide and surfactant use for these babies, and hopefully altering their inflammation early on to prevent bronchopulmonary dysplasia in the long term. And that study will, that multi-center randomized trial will finish soon, so we'll know the results hopefully next year or later. What is nice to see from Vineet was that he thinks he or the group thinks that stem cell based therapies is also probably the emerging potential therapies. And in fact, my group here at Monash is working on both these things. He's mentioned the umbilical cord blood cells, which I've spoken about previously, as well as the amnion epithelial cells. And there are some other therapies available or being tested as well. And especially I'm watching the space for microRNAs and those various mimics and antagonists of inflammatory pathways, which might contribute to these management strategies. So what are stem cell therapies for those of you who are not used to hearing about stem cells? Stem cells, basically, like the word suggests, is those cells which have the potential to differentiate into different organ tissue parts or so on. We have stem cells in almost in all parts of our body. Most common source of stem cells is the bone marrow, obviously, where we have a number of the hematopoietic stem cells, which lead to our various cell lines, whether it's platelets, white cells, or red blood cells. But what we are interested in mostly is the gestational tissue. And the gestational tissue, as you can imagine, obviously leads to a number of important functions in the gestation, in the early, embryological period, which is so important. And what we are going to focus today is the amnion epithelial cells. And the amnion epithelial cells comes from the amnion layer of the placenta. The amnion layer of the placenta has got some very interesting properties, which are highlighted by its use in very early days for caustic burns of the eye. In fact, there has been a renewed interest in this aspect of using amnion as a great regenerative or reparative membrane for burns patients. But also what Ewan and the group in the late 2000s showed that they have pluripotent potential. But what is important is that not only were they differentiating into various body tissues if given the right media and atmosphere to grow, but what is interesting is this panel, which shows that they were very low in immunogenicity. So if you look at the HLA expression of these cells, the freshly isolated amnion epithelial cells, which is basically similar to digesting the amnion membranes and getting the cells from them, you can see the HLA expression is very low. Compare that to hepatic or pancreatic tissue, which is high HLA expression. The HLA expression for amnion epithelial cells is almost similar to controls. So very low immunogenicity, which is a great kind of, I guess, plus point for using these cells, because that means the body in which we give these cells is not going to recognize this as foreign. Okay, so that's a really important property of the amnion epithelial cells. So they are they've got stem-like properties. They're not really stem cells, but they do have stem cell-like properties, which means that they have the ability to perform those important aspects of regeneration or reparation, which might be of use to us. So my colleague Ryan Hodges, in his PhD in the late 2000s, worked with Stuart Hooper and Peter Davis and the group to look at amnion epithelial cells to reduce ventilation-induced brain injury in the fetal sheep. And I'm giving this experiment as an example of how the amnion cell story started and which piqued my interest to actually try to translate them into the humans. So this is an example of fetal surgery being done where the trachea is cannulated in the fetal sheep, and then basically the sheep is returned to the uterine sac, and ventilation is continued. And what they did for ventilation was that they exposed them to in utero ventilation, and you can look at the parameters there. for a few days. And during that time, they had a group which was control, and then they had a group which had the ventilation, and the third group had the amnion epithelial cells given to them. And then this basically experiment of them being ventilated continued for around 7 days, after which the animals were euthanized and their lungs studied. And this is just an example, like I said, of the various animal studies which have happened in this space, which shows this panel, which is looking at hematoxylin, eosin, elastin, and collagen. This is the first panel is the control. This is second panel is the in utero ventilation or the injured model, and this is the amnion epithelial cells being given on top of the in utero ventilation. And as you can see, typical BPD kind of changes happen with in utero ventilation. Similar changes also happen in other models like lipopolysaccharide or inflammation model, which basically the air sacs are destroyed and they are being replaced by fibrous tissue, as you can see, deposition of elastin and collagen. And amnion epithelial cells start appearing to reverse or repair that. This work was shared by Ewan and colleagues with us in the late 2000s when I was finishing my fellowship at Monash. And when I started as a consultant, I kept in close touch with the group and started to work on the story of trying to translate these cells. So if you look at the review from Collins and others in 2017, there are a number of mechanisms by which BPD probably enacts in the cellular molecular space to cause the problems which we have. And we believe that the amnion epithelial cells works on a number of these pathways to reverse or halt that progression to BPD. This could be immunomodulators, modulatory mechanisms, activating the endogenous stem cell or progenitor cells, probably improving the vascular function, and possibly impairing or preventing cell death, which might happen due to oxidative stress or free radical damage. And like I showed in the previous slide, they might be antifibrotic on their own itself. So Jean Tan, one of our previous scientists in the group, showed that one of the other mechanisms amnion epithelial cells might be working is that they might be changing the innate immunity and activating the various T1 to T regulatory pathways, which kind of is going to improve polarization of those M1 macrophages to the M2 macrophages, which then are going to help in the anti-inflammatory and the angiogenic properties of these amnion cells. So this is just one bit of the puzzle which I'm sharing with you in an attempt to convince you that there is a lot of quality data available which shows how these amnion cells might be working. The story of the first in human trial. So this was the first time anyone had given amnion epithelial cells to any human. When I say human, baby, child, adult, old person, we were the first in the world, not only in babies, but in any human. So the story of the discovery I shared with you initially, which showed that HLA immunogenicity was low, the amnion had pluripotent potential, they had some really good qualities which might work, started in 2007, 2008. And Ewan, who was leading this work with Rebecca Lim, started to approach us, and I got involved with them at an early stage, and we started to plan what would a clinical trial look like. And what was key to this, and this is a really important message for anyone planning to translate these therapies or any of these kind of experimental therapies into the clinic, is that if you need to start having those discussions with the human research ethics and regulatory bodies at a very early stage, so that then while you are doing the large animal studies for the physiology, for the small animal study, for the mechanistic properties, you're already kind of thinking what a trial will look like for you to be able to move from that space, so that the valley of death which we see when we move from science to human trials is kind of narrowed as much as possible. There's still a valley, but at least we try to minimize that. So it took us a couple of years from that design and convincing our neonatal colleagues here at Monash to agree to come to the trial. And I am really privileged to work with very open-minded individuals and clinicians who were happy to take the plunge. It took us another couple of years, almost 1.5 years, to move from approval of the ethics trial to actually producing a good quality grade cells to be able to give these patients. So it's not same thing when you're giving cells to preclinical models as compared to babies. We do not need TGA approval, but we need TGA notification, which means that we are following TGA compliant mechanisms to be able to administer these phase 1 studies. And that's the photo of the first baby who was getting these cells. what we discovered very quickly was that we couldn't do this first trial in babies who were very young or very immature. My colleagues rightly wanted to do it in babies with established bronchopulmonary dysplasia. And in fact, most of them were severe bronchopulmonary dysplasia, because the first 3 babies which got these cells got it through only if they were on an endotracheal tube. And those of you who work in neonatal units will know that not many babies at term gestation, when they have got established bronchopulmonary dysplasia, will be intubated. So these were babies who were really, really sick with severe BPD. After the first 3 babies, our colleagues were happy for us to trial it in babies with CPAP. So then these babies were not as sick. They were still severe BPD, but they were not as sick because they were on CPAP after 36 weeks post-menstrual age instead of actually being intubated. So a big ask to recruit 6 babies. It took us a couple of years because obviously not many babies are in those situations. But you can see the days of administration of the amnion epithelial cells went down from 6 months to a couple of months, which is really important to get that first in human safety study going. We had a rude shock with the first baby. We thought we could infuse these cells slowly through an IV push over 5 to 10 minutes, but the baby had quick drop in their oxygen, which is shown in the red, the heart rate, which is shown in the red, the oxygen, which is in the black, and the blood pressure in blue. So blood pressure was maintained, but the baby actually had a transient but definite fall in their oxygen and heart rate, which meant that we had to revise our protocol and we had to go to an infusion. We had to change the concentration of cells which we were giving. So there's already a lot of learning which is happening at that stage, which is telling us that these cells have to be administered in a very different way in the human. And I think the main learning was that these cells are quite large cells, and there's possible that they might stick to the pulmonary circulation and cause microembolic phenomenon. Luckily, the next 5 babies had no problems in terms of their stability during the infusion. So that was really reassuring. What happened to their secondary outcomes? Safety was obviously the main outcome, but the other outcomes was what is happening to their mean airway pressure, or FiO2, and all these different babies in different colors are shown. And as you can see, we did not see any worsening from those cells. So at least they were stable and safe during that first few days. Even the first baby, which is shown in the blue, had that transient phenomenon at the start of the infusion. But as you can see, the overall FiO2 or the mean airway pressure did not actually worsen a lot during that time. So that was the first in human administration of these cells, 6 babies, but a mind-blowing exercise, which then led to Rebecca Lim and her group using these cells for stroke, in adult stroke, for Crohn's disease, for pulmonary fibrosis, a number of diseases which have been running, and many of those trials have actually been completed and moving on to randomized controlled trials. We also did 2-year outcomes of these babies. So we were not just looking at what's happening to them during the time of administration and in the first few weeks of administration, but also 2-year outcomes. And we followed up these babies for 2 years quite closely to make sure that they were not having any risk of tumor formation. These cells do not engraft. So it's not like a solid organ transplantation that they're going to engraft, but still these are first time anyone is administering these cells. So we wanted to make sure that they do not actually lead to tumorigenesis, which was not shown in any animals and so far has not been shown in any of our babies as well. So huge start to that. I can't thank Rebecca Lim and her group enough. And this is our first baby. You can see in the picture, obviously severe BPD, so has got some complications, but is thriving well at this moment. And now I'm going to pass on to Liz to continue the story of this really exciting work.
Thanks very much, Atul. It's a really inspiring journey to listen to. I don't tire of hearing it, Atul, so thank you for sharing with us. So leading on from this, this pioneering work, we've conducting a study called Renewal, or Reducing Neonatal Lung Disease with Amnion Cells. So the meticulous work that Rebecca Lim's lab did in the preparation for the clinical trials showed us that these cells are most effective when they're given early in the course of illness and when they're given in quite high doses. So for understandable reasons, the first in human trial was given to babies who had established lung disease in a relatively small dose. We wanted to move towards what we thought would be more efficacious, but this was still a really early phase study. So what we proposed, just See if I can move my slide along. Bear with me. Oh, there we go. We've skipped ahead a little.
You okay, Liz, or you want me to?
Yeah, maybe if you just skip back a tool, that might, yep. Next slide. We'll get there. So what we proposed with renewal was a dose escalation safety study. So we aimed to evaluate the tolerability of increasing doses of intravenous allogeneic amnion cells in preterm infants at high risk of BPD. So we aimed to administer these cells earlier and at higher doses. Let's see if I can get it to work this time. Great. So our target population. To justify the risks of this early phase study, we wanted to recruit infants who were at high risk of severe BPD. And that's really quite challenging to define within that first month or so of life. But we in the end, after a bit of work looking at the cohort of babies between our two recruiting centres, we settled on these criteria. So infants that were born at less than 29 weeks gestational age, who on day 14 or day 21 after birth, so within that first sort of 3 to 4 weeks of life, were ventilated in more than 25% oxygen or receiving non-invasive respiratory support in 35% oxygen or more. The intervention that we proposed was, as we've talked about, intravenous allogeneic amnion cells. And that we used a dose escalation protocol. So we started with administering 2 million cells per kilo, and we escalated the dose in a single infusion up to 10 million cells per kilo. And beyond that, we are giving infants repeat doses to try and get the dose up to a maximum of 30 million cells per kilo, which based on our animal models, we think is most likely to be efficacious. The primary outcome of renewal is safety, and we plan to demonstrate this by the absence of adverse events. So what are we looking for? What are the adverse events that we can predict? Well, we're looking for immediate tolerability of the intravenous amnion cells. We're looking for any evidence of allogeneic rejection, and we're looking for evidence of tumour formation. Now, we've got some really good preclinical evidence to suggest that allogeneic rejection and tumour formation are really very remote possibilities. As Atul demonstrated to you, the cells actually have very limited expression of HLA antigens, so we don't expect the infants to mount an immune response to them. Similarly, the cells actually don't stay within the body. They don't engraft. Our animal models suggest that they stay within the system for about 5 to 7 days and are cleared beyond that. So the opportunity to form tumours on the basis that they engraft is really very limited. And in addition to that, as much as we've tried to encourage these cells to form tumours in preclinical models, they just don't seem to do that. We are, however, following our infants up until they're 2 years corrected. How do you define tolerability? Well, we're doing this by watching infants' cardiorespiratory stability during the infusion of the product. So we've got to remember that this is actually a relatively dense allogeneic cell product. So we're looking out for events such as the one that Atul described in the first infant who received these cells. Then we're looking to see that they remain stable for the 72 hours post the infusion. And again, we're defining this as no escalation in respiratory support, no escalation in cardiovascular support, no infections, and that their baseline vitals remain within 30% of their baseline. So if we reflect back on the population of infants that we're recruiting, so less than 29 weekers who at 2 or 3 weeks of age are either ventilated or on non-invasive support, with quite high oxygen requirements. I hope that you can appreciate these are actually really quite strict definitions around tolerability, that these babies are at risk of needing an increase in respiratory support. They're at risk of late onset sepsis and the other parameters that we've described there. We'll obviously plan to report secondary outcomes, so the usual collection of neonatal in-hospital outcomes, but with a particular focus on respiratory outcomes. And if you just click the next, the other secondary outcome that we're going to explore is some cytokine profiling. And I think this is actually one of the really interesting parts of this study and results that I'm looking forward to seeing. So we're taking blood pre-infusions, 24 hours post-infusions, and then a week after the infusion. I think this will help. I guess this is really exploratory. We're looking to see if these results might help inform us a little bit more as to the mechanism of action and to profile these infants in a little bit more detail. So we planned at the beginning to recruit 24 infants. As I've described, we had 6 dose cohorts with 3 infants in each of cohorts 1 to 4, and then 6 infants in the final 2 dose cohorts. So the final 2 dose cohorts are the infants who receive multiple doses. We started recruitment in 2018, so a number of years ago now. And we're currently, well, actually, as of today, we finished recruitment to our second last dose cohort. So actually, rather than 7, we've got 6 babies to go after an infant received an infusion today. I think lots of clinical trials have been challenging during the pandemic, and certainly we experienced some delays because of that. But in addition to that, we've got really quite strict reporting criteria and many planned safety reviews. We need the okay from our safety data committee prior to escalating the dose. So there's multiple reviews along the way. So recruitment's been slow. But what have we learnt over the last few years? We've learnt that early phase studies take a long time and that you need lots of patience. Collaboration is incredibly important. So translating something like amnion cells into a really vulnerable population has taken collaboration between the investigator group, between us and the preclinical scientists, those that really explored how these cells work and can help describe to us their mechanism of action. It's taken an enormous amount of collaboration with the ethics committee, and I think Atul described that beautifully from very early on. Having a close relationship with that ethics committee has facilitated both of these trials. We have a really, we'll just skip back a bit, Atul. We have a really a great working relationship, I think, with our safety committee, and they're very much involved in the study and have been instrumental in helping us move forward. We've also learnt that these studies require an enormous attention to detail, and I hope that what the next couple of slides will demonstrate that. So what we learnt, or what we've developed along the way, is a cell therapy infusion protocol specific to neonates. So what I noticed at the bedside of the first infusions was that I could actually see the cells accumulating in the IV line that we were using to administer them. And we had no idea what effect this was having on the dose that we administered to babies. Next slide, please, Atul. And so you can see here the syringe that we were using to administer the cells. You can see a collection, a little cloudy collection that forms at the exit point of the syringe. These are the cells settling in the line and the syringe. So we stopped recruitment and I went back to the lab and explored what effect this was having on the dose we were administering. And what we found was that about 50% of the dose actually remained in the syringe. Around about 25 to 30% of the dose got stuck in the line, and we're actually only administering around 20% of the intended dose to infants. So I spent a number of months in the lab developing a protocol or exploring what factors influence the delivery of cells, and following that developed a protocol that actually just used really readily available equipment to create a more reliable infusion protocol. So you can see here a comparison of the dose delivered using the old protocol versus the new protocol. So now we know that when we're administering cells, we are actually administering the dose that we'd intended. And the way that we do this is by suspending the cells in 4% albumin. We use a short intravenous line, so the cells have little opportunity to collect in there. And we invert the syringe. So rather than having a horizontal syringe, we position the syringe vertically. And really, these simple maneuvers have made an incredible difference. So attention to detail is really important. And this is a protocol that we've published, and we're hopeful that this will provide a foundation for cell therapy infusion protocols in neonatal cell therapy, not just for amnion cells. What else have we learnt? Well, we've learnt that the cells are actually pretty well tolerated once you get these bits and pieces ironed out, I guess. So the next slide shows you some graphs that were generated from the first 8 babies, and this shows their heart rate, their oxygen levels, their blood pressures, and respiratory rates during the hour-long administration of cells. So you can see that the babies remain pretty stable during this period. What else have we learnt? Well, as we start to ponder sort of next phase studies, we've learnt that there's lots of manufacturing considerations to address. At the moment, we use fairly limited clinical release criteria, but as we move towards a phase 2 study, I think we really need to nail down some more clinical release criteria that relate to the potency of the cells. Feasibility is a really important one. So we currently collect the donors that we use for these studies are women who've had uncomplicated pregnancies who deliver their babies at term via an elective cesarean section. And we can collect around 200 million cells from each placenta. And that sounds like a lot of cells, but once you do all of the potency testing that we need to do on them, once we test the product for bacterial contamination, once we thaw it down and we lose a few cells in terms of their viability, we can probably treat around 2 babies from each placenta. So this is something that we really need to think about as we're moving to phase 2 studies and looking to recruit higher numbers of babies. And Atul alluded to some of these regulatory considerations as well. So currently our cell infusions are manufactured in a good manufacturing or a centre that's compliant with good manufacturing practices. But to move to later phase studies, we really need to look to manufacture these cells in a licensed facility in line with TGA requirements. So there's lots of things to consider. But most importantly, I think we've learned that there's still a lot to learn. Each time we infuse babies, we're learning things. We learn things about the infusion, we learn things about how babies tolerate them, we learn something about the manufacturing process. And that's really exciting that there's still so much, that there is so much to learn. But I guess it also illustrates that these things take a lot of planning, and they take a lot of patience, and they take a lot of collaboration. So I hope what you can take away from Atul and my talk today is that, as you all know, BPD is a challenging and important morbidity for our preterm population. And BPD is probably on the increase. It's a multifactorial disease, that's borne out by prematurity, by an interruption to the normal development of lungs, interruptions because of preterm birth, because of conditions such as hyperoxia, infection, ventilator-associated lung injury, which all modify the way alveoli develop. But what we've been able to show in our preclinical models is that human amnion epithelial cells can restore lung architecture. They can really modulate the inflammatory response within the lungs to create an environment that's more conducive to alveologenesis. Okay, next slide, please. So renewal and the work prior to renewal in Atul and Rebecca's first in-human trial has detected and resolved some really important knowledge gaps for amnion cell therapy in neonates. But there are many still to be addressed. And what we aim from this study is to report a tolerable dose of amnion cells, which can provide a foundation for the next series of amnion cell therapy trials. There's many people to acknowledge. The renewal team and a number of institutions who are involved in supporting this study. And lastly, but absolutely by no means least, is the families that are involved in this study. Next slide, Atul. So this is a picture of the first infant who was recruited to renewal. You can see a picture there of the day he received his infusion. The next pic is when he was 6 months old, and then at 2 years corrected. So without courageous families like these, early phase studies like renewal wouldn't happen. So thank you to the families involved. Okay. So I think that's it from us in terms of talk.
Perfect
but we're really
timing.
happy to answer some questions.
Yeah, perfect timing, guys. Well done. It's like a well-oiled show. All right, while they're getting ready for their talk, for their questions, can I ask, if you were designing the RCT, what would be your primary outcome?
Julie, it's a really, I think it's a question that's pertinent not just for renewal, but for lots of RCTs at the moment that are looking at therapies to improve lung health. Our standard composite outcome of BPD or death, I think we're all recognise the limitations around that as a primary outcome, and a balancing that with those outcomes that we think are probably more important in the longer term. So it will focus around respiratory outcomes, but exactly watch this space.
Because this is slightly different to the other trials, right? The other trials will be you're starting to see whether the child develops BPD. This is a cohort that has established BPD.
So I think what we've looked to for next phase studies, Julie, is so renewal is treating babies who are about 2 weeks to 4 weeks old. So they're still quite immature. Next phase studies, we'd certainly look to move that treatment age to younger than that. We know from the preclinical work that the cells are most efficacious when they're given earlier. So, I think we'd look to try and get the cells in perhaps within the first 2 weeks of life rather than weeks 3 and 4 of life. It was a step too far, I think, to move from term babies or ex-preterm babies at term corrected to then treat babies within, 24, 25 weeks within the first week of life. Hence, renewal was sort of a compromise between that.
Yeah, one of the things I'd just like to add, Julie, one of the things is always challenging in therapies like this is choosing the right patient. So, you don't want to go in too early as well. Even if you move to the next phase, you want to target babies who are at the highest risk of BPD. And, there are a lot of calculators and tools available. None of them are perfect, and they get more sensitive and predictive the further you go down the line of their age, but by then you're kind of missing the boat. So we need to find the right balance, and I think Liz and I feel that it's going to be in the first week or 10 days of life where we'll be able to consider it. There have been some bench studies where we've actually or the team has actually mixed it with surfactant as well, a bit like the budesonide work going on at the moment. So it is stable with surfactant as well, but I think it'll be loath for us to say that we'll want to do that as the next step. We would probably want to do it in the highest risk population, and that might be extremely micropreemies or the babies who actually have significant requirements in the first week of life. I think that's where we're headed.
Thank you. All right. No questions at the moment. I was going to put Medicine Pattern on the spot, but she's disappeared. She's run away. So maybe I can ask Paul Koditz to unmask himself. Paul, you work a lot with your brain, but do you have any comments on amnion stem cells? Oh, he's very shy.
Yes. And sorry, you're seeing me in the dark. Just let me.
That's okay. I'm in a car. I'm in a car park.
So
you can't beat that. I'm in a car park.
Yeah. So look, it's a very interesting question, isn't it? And of course, how will the cells themselves work? They're being administered to the lungs, but they're likely to induce systemic anti-inflammatory effects. And of course, particularly that group that Atul just identified as perhaps the most likely initial targets, sort of sicker, more premature babies early, are likely to have blood-brain barriers that could be responsive to either the mediators or potentially even the cells crossing into the brain and mediating anti-inflammatory effects in the brain. So certainly some sort of neurodevelopmental outcome ought to be amongst the secondary outcomes. But look, it is challenging, isn't it? Of course, we're reliant on things like Bailey's that are not, we need better brain tools, and various groups around the place are working on that, of course, but, we shouldn't ignore our standard Bailey endpoints. Thanks, Julie.
Paul, I think you make a really important point. And we did preclinical work looking at both giving these cells intratracheal and giving them systemically. And we've settled on giving them systemically because we think that they may also have some neuroprotective effects. And we've got some animal data to support that. So whilst our current work is sort of focused on defining and demonstrating the tolerability in a group of babies who are at risk of lung disease, we're very cognizant of the idea that these cells might offer some neuroprotective capacity as well.
Is there any problem in giving it to the babies as soon as they're born? So, if you wait even a couple of days, there is, enormous damage. We do enormous damage to the lungs, to everything, just to keep them alive. So you pop a UVC in, you give your amnion cells, it filters to the brain, to the lungs, whatever. Is there an issue there?
Do you want me to tackle this one at all? Or...
Yeah,
I'm nasty, aren't I? I'm nasty.
No, I think no. It's a really interesting question, and it might be that one day we do get there, Julie. But from a demonstrating safety and tolerability perspective, we're not there yet.
And along that lines, Julie, one more thing I want to talk about, which we did not cover here, is that these are cell therapy lines which we are using. The group is actually doing some fantastic works on acellular lines, which are using the exosomal or extracellular vesicle bits of amnion cell lines In fact, we are doing now large animal studies, which I'm also part of at Monash, trying to see if the extracellular vesicles from these cell lines are as efficacious as the amnion cell lines were in those animal models. So that's really exciting, because one of the issues with this cell, which we have spoken a bit about, is that they are quite large in size, and the potential risk of a very unstable early kind of postnatal age baby is that pulmonary hypertension and the circulation being very sensitive to big swings is big risk. And Paul talked about the cerebral circulation being pressure passive as well. We've got them in albumin, and albumin is not without risks as well. So I think it is possible that we may actually move on to other ways of delivering this regenerative medicine instead of using the cell itself. But I think what is next kind of logical step moving forward is like what Liz said, moving them to babies who are beyond their first few days of that unwellness from a lung point of view, and have settled down by the end of the week or the first 10 days of life. That's what we think is most likely where we're going to land, but we will need a lot of consultation and collaboration with colleagues, with patient, consumer, and stakeholders.
Thank you. Any comments? You have one little message at the end from Julie Wixie. Hello, Julie. Do you have any cytokine response results from your animal studies? You mentioned you're planning to examine the cytokine response caused in the humans. Atul, Liz, who wants to take that one?
Yeah, Liz can speak to this, but yeah, I was hoping Liz will be able to find a slide which we can share, which I've also got a few, but I think there's very good animal data or preclinical data to suggest the immunomodulatory and the anti-inflammatory properties of these cells. They are, I would say, more targeted towards lung inflammation. The brain inflammation bit has not been so positive. I'm talking about brain, Julie, because I know you will be interested in the brain, but definitely there are very good indicators of dampening or modulating the lung inflammatory markers, both at a cellular level, but also at a systemic level.
And I'm just quickly whizzing through to see if I can show you a quick slide, but I don't think I'm going to be able to do it smoothly enough. But I guess just to reiterate what Atul has said, we certainly have seen a decrease in inflammatory cytokines and an increase in protective anti-inflammatory cytokines in our animal models. So
systemic. Do you want to unmask yourself, Julie, and just ask them the questions yourself? Perfect. She's happy.
Hello. Sorry.
Hello.
Yeah, I'm very happy. I was more concerned about, because we're looking at some stem cell treatments, and our recent paper that we published, actually there was more of a response with the anti-inflammatory cytokines rather than dampening of the pro-inflammatory cytokines. So that's what I was quite interested in.
We see a same kind of suite of kind of patterns that in some models there seems to be a dampening of the anti-inflammatory, and in some of them actually we get a pro-inflammatory response as well. So yeah, it's quite interesting. But as you can understand, the animal or preclinical models never mimic the human response completely. But that's why the data which comes out of the renewal study, which Liz will look at the end of the next 6 infants, will be really, I think, eye-opening, hopefully.
Lovely. Thank you. Beautiful study, by the way. Thank you.
Okay, Shiv first asks, can you tell us a little, that's a good one. How do you get those cells?
Liz, you want to answer that? Or I can?
Yep. So the cells come from women who have had an uncomplicated pregnancy, who deliver their babies by a planned elective cesarean section at term. So we're often asked the question about, well, can we use an autologous amnion cells? So can we harvest these cells from the placentas of the babies and give it back to them? But Rebecca Lim's group did some really lovely work early on that showed that the preterm amnion cells don't have the same capacity to modulate the inflammatory response term amnion cells. So hence that we're using allogeneic cells. So essentially what our team do is they attend the cesarean section. They collect the placental products and essentially strip the amnion from the placenta, digest it, so to release the amnion cells and harvest them that way. They undergo some testing, so we do some potency testing, and we do some endotoxin testing before the cells are banked, and then once we are ready to infuse, the cells are thawed, washed, and suspended in albumin.
And
we
how
don't
long does that
actually
all
have
take?
to, because the cells are quite plentiful, unlike some other cell lines, such as mesenchymal stromal cells, the cells don't need to be replicated prior to banking.
So what Liz is saying is that we are not kind of culturing them or conditioning them at all. So they are basically innate cell lines on its own.
And how long does it all take, guys?
The process of the process of harvesting doesn't take a long time at all. But when we are actually taking them out of storage, cryo storage, and kind of thawing them and doing the various steps of making sure that they are usable, takes around 3 hours or so, which sometimes takes longer, like I saw today. So we have to do a lot of batch testing to make sure that these are cells are kind of passing the quality controls of various things, of not just viability but contamination, endotoxin testing, and so on. And you can see in a preterm, we don't need a lot of cells. So sometimes the same infusions, like we're doing 2 infusions for the current baby and then 3 infusions in the next slot, will all come from a single donor. But in an adult, sometimes there can be multiple donors required as well. So yeah, it's a complex process, but yeah, for preterm babies, it's pretty straightforward.
That's not too long. A day you can get your cells, right? You can get usable cells in a day.
Yeah, because you're banking it from allogeneic source, Julie, that's not a problem at all. The therapy I talked about earlier with the autologous cord blood cell therapy, that's a slightly more tricky process. But this one, we have cells banked, and preterms, like I said, don't need a lot of cells per kilo, so they are pretty straightforward. It's the bigger populations which becomes more tricky.
No, that's good. Mm-hmm. Thank you. So are you happy, Chef? Happy? Yep, thanks, he says. Yeah, all cool. Okay. Just quick question. Before I go into Vijay, sorry, Vijay, you can unmask yourself. Do you have to match these cells to blood groups or anything, or you can just plonk into any kit?
No, that's one of the beauties of these cells, is that they don't need to be matched. They have very limited HLA expression, so they don't need to be matched.
So anyone can.
Yes.
Okay.
Yeah.
All
so
right.
no minimal HLA expression, like I showed in that slide, and no blood group expression. So it's not, and that's why I think they are really exciting. In the stroke team, they just got around $10 million to do a randomized trial in the stroke patients, in the adult stroke patients. So it'll be really, exciting to see if they can, because that'll be a game changer. It's off the shelf product which can be easily used.
Yeah. You pick it off the shelf like a surfactant. Okay, Vijay, your turn to ask the question. Go, Vijay Shingdi.
Hi, Atul and Liz. Great work, fantastic work. Just a question, I believe there are adult stem cell infusions are available on shelf. And I'm just wondering, what's the difference between your amnion cell and the one ready-made you can actually give it to patients?
Yeah, I'm happy to tackle that, please. So, when you come to these stem cell clinics, there is a big attempt to clamp it down in the United States, because there are these number of clinics which kind of are selling products which come from various sources. Some of them are mesenchymal stromal cells, and mesenchymal stromal cells, like as the word suggests, is from the mesodermal cell lines, and they can be from the bone marrow, you can actually manipulate and have induced pluripotent cells from any cell line of the body and produce them. But one of the things with these stem cell clinics is that their regulatory processes is very difficult to kind of analyze, as simple as apples and oranges almost. So it's very difficult to compare one cell product from a clinic to another cell product. And that's one of the things which I think Liz alluded to earlier, is that we want to have a product which is easily replicatable and has got the quality testing which passes the grade each time. And I think that's the problem with these clinics, is that we don't know what they are doing to actually do quality testing and producing a product which is same each time you give it. And it's a big challenge. The adult stem cell clinics or cell infusions which people have, most of them now are induced pluripotent cells, and you might be aware of the manipulated CAR T therapy, which is the most kind of prevalent therapy now in the hematological oncological space. And these are all manipulated cells from various cell lines, and they are taken down passage and culture to produce what the product might be most reliable. But what has happened is the various companies produce the product which works for their kind of cell and patent, and then those are used for various indications. But we are taking baby steps as compared to that space. So this is much more regulated and much more, considered. Liz, do you want to add to that?
No, thanks, Atul. Thank you. I think you've explained it really nicely.
Can I ask about the costs though? What was the difference with the cost between what Vijay has said with the stem cell bank companies to Amnion cells?
Oh, so if you have a patent on it, and you can put a price whatever you like, and that's the problem which the FDA is trying to clamp on in the States. Obviously, we have a small market, so we don't have that kind of risk. But there are a number of trials going on in Australia as well for various adult conditions, for not just Amnion, like I mentioned, but for various other cell lines. There are a few big players in the market who are regulating that, who are controlling that space as well. But the cost is very variable, Julie. It's very, very variable depending on the need, the market space, and the patent associated, and so on.
Okay, but at the moment now, you're harvesting it from the centers and it's free.
No, so right now it's an investigator-initiated thing. This the technology of Amnion cell banking and storage, the tech transfer has happened now to actually a Queensland company. It's called GenQ, and basically they are going to look after the production and kind of storage of the Amnion cell lines from now on. And like Liz said, in trials which are beyond phase 2, phase 3 trials, which are randomized and so on, we will actually be using a TJ approved facility. For example, in Melbourne, it's the St. Vincent's Cell Therapies platform for this particular therapy, which we'll be using, for the bigger trials. So obviously, as you can imagine, when they are completely TJ regulated and approved, the costs go up, because obviously it's a lot of quality control which needs to happen, which is appropriate, because when you're in early phase, you're trying to see if it's actually really worth investing in those spaces. It's different to when you're actually wanting to trial it in bigger populations. So yeah, a lot of things to consider, and it's not easy, but I think it's all worth it given the cost which these babies, kind of we invest in keeping them going, and the ongoing cost, lifelong cost associated with morbidities.
Oh, sorry, I'm muted. All right, lovely. I think that's wraps up our time. If there are no other questions, maybe whoever has questions after that can email Atul and Liz separately, or get in contact with us. This recording will be uploaded to the WhatsApp group and to our UNESCO site eventually, if you guys are happy with it. So I'll let you have a look at it and see whether there's anything dodgy that you don't want to show, and then we'll upload it if that's okay.
No worries. Thanks, Julie. Thanks so much for having us.
Thank you, everyone, for your
for the
great questions and for the fantastic presentation. Very exciting potential therapy for BPD kids, and probably for the neurodevelopment as well. So we're watching your space. Thank you, guys.
Thank
Have
you.
a good night. Thank you. Bye, everyone.
Bye.
Bye.